Welcome to Verbals on sanitation and hygiene. Our first presenter today is going to be talking about improving prediction of nutrient recovery via struvite precipitation from organic waste digestate. Please welcome Haidar Aldaach.
Hello, everyone, and welcome to my presentation. My name is Haidar Aldaach. I'm a PhD student from the Department of Civil Engineering at West Virginia University. As you can see in the screen, the title of my presentation today is Improving Prediction of Nutrient Recovery via struvite precipitation from Organic Waste Digested. So data science provides an opportunity to reduce the environmental, social, and economic impact while improving the nutrient recovery technologies, and thus could help to achieve different United Nations Sustainable Development Goals, SDGs. So the most relevant SDGs related to my work is SDG 6, which is ensure sustainable management for water and sanitation for all people, and SDG 14 that aims to conserve and sustainable use for ocean, sea, and marine sources. So addressing the targets of these goals could help to achieve another SDGs, such as SDG 1, no poverty, and SDG 2, zero hunger, and SDG 12, response consumption and production. So this slide shows the treatment train diagram where different organic waste can be recovered to new resources beneficial for the community. As you can see in the screen, there are different feedstocks can be utilized using different technologies, and these technologies uses different physical and chemical processes to recover resources from the feedstocks. So one common strategy to recover the organic waste streams is anaerobic digestion, and the effluent from anaerobic digestion is called digestate. Digestate can be separated mechanically to solid and liquid fractions, so to recover another resources. So the liquid fraction can be recovered for nitrogen and phosphorus by the process or technology is struvite precipitation. And through the precipitation process, the nutrient-rich digestate can be recovered by adding the magnesium and base to be used as like a struvite fertilizer, and that's beneficial to the community. So the red box in the top shows the study's main focus treatment track. So data science provides the foundation for artificial intelligence and machine learning function to learn and solve real world problems. And if we compare it with the statistical methods, they offer powerful tools for uncovering hidden patterns, making a prediction, and automating decision-making processes. Also, these methods can help analyze complex data for water quality, sanitation infrastructure, and hygiene behavior, and thus leading to improve public health outcomes. So the expected impact for this study, data-driven models can help to optimize different parameters affecting the ammonium and phosphate recovery efficiency, and thus could help to improve the efficiency of struvite crystallization, reduce the cost of treatment, and reduce the reliance on laboratory work. So thus, the general goal of this study is to quantify the effectiveness of statistical and machine learning models in predicting the percentage of a nutrient recovered from digested derived from different organic waste streams via struvite precipitation technology, for sure. So this research was progressed based on 3 objectives. The first one, investigate the effectiveness of different parameter control the nutrient recovery using struvite precipitation, such as pH, molar ratio, and reaction temperature, and also identify the effective sample size for modeling, and determine the best model that's doing the best job for prediction the nutrient recovery efficiency. So this slide shows the general framework for this study. So to achieve the prediction of different data-driven models, we followed 6 main steps for the prediction. I'm not going to go through the details due to the limited time. So the data set for this study derived from 26 peer-reviewed publications for different nutrient recovery technologies skills, like pilot skills and laboratory skills. The sample size for our study developed our range between 74 and 1,062 for different prediction model collected, as I mentioned, pH, molar ratio, etc. And the data set included various resources of wastewater, such as swine manure and dairy wastewater, as you can see in the screen. So this slide, it just shows the table that show the two scenarios developed for this study based on the number of input variables or predictors and the sample size. So we have 9 combinations, and we have a different number of studies on different organic feedstocks used. So the result of this study shows low prediction performance for statistical models if we compared with the machine learning. And also the only 2 sample size that are effective in our study was 506 and 74. There were also 10 input parameters. They were the best choices to predict ammonium and phosphate recovery, such as pH and mixing speed. Random forest was the best model for scenario 1, and XGBoost was the better for scenario 2. And we can summarize like the results for scenario 1. We have combination 3 with four input parameters using random forest model to predict the phosphate recovery. The same thing for combination number 5. And we have 10 input parameters for scenario 2 to predict the phosphate and ammonium recovery based on the tree-based model XGBoost. So this slide shows the scatter plot between the actual value and the predicted value for different training testing data sets. So for combination 3 for phosphate recovery, we can see like the R square for the training data set. Sorry, for the R square, it just shows the similarity between the X and Y values. So the R square for the training data set was 0.94. And for the testing, 0.72. That's for the phosphate recovery combination 3. For combination 5, the R square for the training data set, 0.98. And for testing data set was 0.95, which shows promising results. So follow up with these slides for combination 8 and 9 for phosphate and ammonium recovery using 10 input parameters. R square was 0.96 for the training data set and 0.93 for testing data sets. For the phosphate recovery, for the ammonium recovery, R square 0.92 for the testing and for training, and 0.87 for testing data sets. So this slide shows the feature important analysis that shows the most influential parameters that has significant effect on the required output model. So we can see like for combination 3, the molar ratio of MGB was the most influential factors that affect the output, followed by the molar ratio of nitrogen phosphorus. And we can see the reaction temperature, pH, has less contribution on the output model. This is for combination 5. I just show the feature important analysis, the molar ratio to predict the ammonium recovery. So the molar ratio of nitrogen phosphorus has the most influential, or the most contribution that's influenced the output, and there is less significant contribution for molar ratio, MGB, and pH. So for combination 8, we can see like the ammonium recovery has the highest influential impact on the prediction model. And there is followed by the coexisting ions and pH value. For combination 8, to predict the ammonium recovery, we saw the operational parameters has the most influential impact on the output, with more than a total of 85% of the total contribution. So the conclusion, the tree-based model, random forest XGBoost, shows the best prediction model for ammonium and phosphate recovery. The sample size has no clear impact on developing the data-driven model in our study. And the feature important analysis shows that the reaction temperature had a low contribution in predicting the outcomes, and machine learning need to be developed considering a feedstock type as a predictor in future studies. Key takeaways: data science can be used to model the efficiency of nutrient recovery by struvite precipitation. There are limited machine learning models that developed to predict the nutrient recovery from digestate as a source of wastewater. Machine learning model, better prediction than the statistical model, and the tree-based model, random forest XGBoost, shows the best prediction for phosphate and ammonium recovery, and changing sample size had no clear impact, and the only two sample size was 506 and 74. There are also 10 input parameters where the best choices to predict the outcomes. Thank you for your attention.
So much. We have time for a couple of questions if anyone has anything they'd like to ask.
Actually, this work is going to be published by the Environmental Engineering Science this week. I submitted all the second revision, so it's supposed to be published this week. Thank you. Thank you so much.
So much.
Thank you.
All right. Up next, we will be hearing from Dani Barrington about intersectional vulnerabilities and lived experiences of container-based sanitation in Kenya, South Africa, and Peru.
And now for something completely different. There's no numbers in my presentation. I'm going to be presenting on a small part of a much larger project, the scaling up off-grid sanitation project led by Cranfield, by Alison Parker here. So this is just the intersectional vulnerabilities team. So you can imagine it is quite a big project in general. Okay, and what also throws you here, you can see yourself on video. So firstly, I just wanted to note that I live, work and play on the land of the Whadjuk Noongar people, the traditional custodians of the land in Australia, or in my part of Australia, and that land was never ceded. And I pass my respects on to their elders, past and present. So I'm going to give you a really quick crash course in container-based sanitation to set the scene. When we talk about container-based sanitation, we're not talking about a technology, we're talking about a whole safely managed service chain. But today, I am going to be talking about user experiences. So I'm going to focus on the containment and emptying part of this chain, because that is the part that the users are generally involved in. So we've been working with users of container-based sanitation, or CBS, in 3 different countries. In Kenya, we've been working with users of the Sanigy toilet, which is this Fresh Life toilet. It's a urine diverting dry toilet. It's got a squat pan. Sometimes they're in households or often on plots, so shared between a certain group of households. Sometimes they are public, and so people either pay per use for them or they have a subscription for use. Sometimes they're provided through schools or churches. So lots of different models there. They are emptied every day by Fresh Life operators, and the waste is then composted. In Peru, we've been working with users of the Sanama toilet, which some of you might know as X-Runner. They changed names a couple of years ago. And they also have a urine diverting dry toilet in the middle there with a vent pipe up the back. These toilets are in households. So almost all of the sanitation in this part of Pamplona Alta, which is the community we've worked with, the sanitation is all at the household, and households pay a subscription to Sanama. They empty these a couple of times a week, and they have to actually carry the buckets of waste to a transfer station where a little truck that plays music like an ice cream van comes and picks it up. And then that waste currently is mostly going to solid waste landfill, but they are doing a pilot with composting. And then on the far side, we've been working with users of the portable flush toilets, or PFTs, in Cape Town, in BM section of Kailicha. And this toilet, you can't really tell from the picture, but it's about 1/3 smaller than the Sanama toilet, and it's a lot ricketier. It's not as good a quality plastic, and it's a bit wobbly, I think I would say, if you were to sit on it. This is a flush toilet, so people are encouraged not to put too much water down there, but everything does go down the one hole into the tank at the bottom, and those tanks are then collected by a city contractor a couple of times a week, ideally from the households themselves, and ideally you get back your tanks. I probably should have noted here with Sanoma, often there is like pay per use, or it's included in your rent if you're living on a plot and don't own the house. Sanoma, I said, was subscription, and Cape Town, it is free to the users. So the part of the project that I work on is intersectional vulnerabilities, and we're trying to understand whether the most vulnerable users of container-based sanitation in our settings have an improved sanitation experience compared to people who use the other sanitation options. So it's very difficult in a 10-minute presentation to go into intersectionality. Intersectionality is about all of the different ways in which a person experiences the world. So for me, I'm a woman, I'm Australian, I'm middle class, and all of these things, they intersect to make the way that I experience the world. So it's not just about, when we're talking about people's experience, you can't base it on just one part of their life. It's all about these many things. But because I don't have very much time today, I'm not going to really go into how these different experiences all intersect. I'm going to focus more on the practical takeaways of what we're seeing with CBS in these very vulnerable communities. So we've been using something called photo voice. And in this method, what you do is you actually work with your participants. So in our case, we had some users of CBS and some non-users, and we trained them up into how to take photographs, and that we asked them to take photographs about sanitation and how it impacts their daily lives. They then went off for a few days and took photographs, either on a smartphone or a disposable camera, depending on the context, which I don't have time to go into. And then we printed out their favorite photos and asked them to write captions for them. So what is it you were trying to capture when you took this photograph? And we then interviewed each of the participants and talked to them about why did you take this photograph? How is it representative of your sanitation experience? What is often done in photo voice, and we have done in this project, is the photographs and the captions are then often used in a public exhibition. In our case, with the people who took the photographs, but also other members of a community. You can also have government officials, politicians, the general public, and we've had a big mixture of that as people who have viewed the photographs since. So just to give you a snapshot of a few of the interesting findings. So in South Africa, the portable flush toilet is the only household sanitation that's provided by the City of Cape Town. The City of Cape Town does have to provide people with free sanitation, but most people are actually using shared sanitation. And that has its own issues. So for example, you can see here, these are photographs that were taken through Photo Voice. This was a person who was trying to show that the distance to, the right one? Yep, the distance over here to the toilets, they have to cross through this very flooded area, and it's quite a long way. Also, if you're someone who has mobility issues, or if it's nighttime and you're a woman and you don't feel safe. Some people would just openly defecate because they didn't feel safe even using the shared toilets, or because of power differentials within the community. People may have been assigned a toilet, but they may not have access to it. They may not have a literal key to be able to use it. Whereas the people who were using the portable flush toilets, they had household sanitation. And we did find that generally they were happier with the sanitation situation than the people using shared sanitation, but there were still some issues there. So particularly there was this, just assumption by the City of Cape Town that when people had these portable flush toilets, they would have somewhere to use them in the household. But most of the people are living in a one-room shack and didn't want to be defecating and urinating right next to where they sleep or where other members of the family are. So in order to be able to actually use these PFTs, people needed to be able to build a small area off of their shack. So they needed materials or money. They also often needed to have built enough social capital to have someone help them build it or to build it for them, particularly if they had a disability that was something to do with like mobility or vision, that kind of thing. And they also found that because it is quite a rickety toilet itself. People with different mobility issues need to be able to actually adjust it and adapt it to their needs. So even though the container-based sanitation did seem to improve well-being more than the other options, there are still a lot of issues for people who are very vulnerable. In terms of exhibitions in South Africa in particular, as well as the more traditional photographic exhibitions, our team also made up a photo essay and gave it to the Mayor of Cape Town, who read it on a flight, I think, to Pretoria, and has since started working, his office has started working with members of the University of the Western Cape team to actually do more of a review of looking at how the CBS toilets are serviced in the communities and bringing in a lot of staff who perhaps had planned how these things would work, which don't necessarily work in reality, and people who've never actually been into BM section to see what the reality is like on the ground and work with users to make changes. So that's pretty cool, actual on the ground changes. In Peru, most of the households in Pamplona Alta do have household sanitation, be that a Sanema toilet, a different type of compost toilet, or a pit latrine. A couple of big takeaways from the photo voice was that even though people liked the Sanema toilet, having to carry the waste to the transfer stations was particularly difficult for people, for women and for people with mobility issues, because it is a very hilly area in particular. So you'll see this person having to carry up these lots of steps. And that's when you're lucky enough to be somewhere with steps and not scrambling up to it. And another issue that we saw that we hadn't thought about a lot was that people who had pit latrines had a place for their grey water and their bathing water and other water uses in their household to go into. But people who were using compost toilets, the other water that they were using in their household was draining onto the street. And because they live on a slope, it then would drain out in front of other people's houses and things. And so then you start seeing issues around social cohesion and people actually having arguments in the settlement. And then finally in Kenya with the Fresh Life toilets, one of the issues that we saw with them, I think we did see that people were generally happier with the Fresh Life toilets than they were with other sanitation options. But one of the big issues was access. So having access 24 hours a day. So even if you had a Fresh Life toilet on plot that you shared with just the households around you, the key was often kept by the landlord. So you didn't actually have access to it if the landlord wasn't there or it was nighttime. And we also saw that there's possibly some discrimination going on, particularly around religious, different people who practice different religious practices, around sanitation. So for example, people who identified as Muslim in our photo voice said that there was sometimes discrimination around them for not being able to rent places, for example, with Fresh Life toilets because people weren't happy about the water usage because that would interfere with the container-based sanitation process. So essentially, overarching findings is that container-based sanitation does seem to be better for the most vulnerable people in these settlements. They did seem happier with their sanitation than other people using other sanitation options, but there's still a long way to go. There's still a lot of things that we can do to help improve that lived experience. We don't have a project website, but if you follow me on LinkedIn, I will share things. I share our publications as they come up so you can see them. Thanks.
So much. Do we have any questions?
Yep. Oh, microphones.
Two?
Oh,
there we go. Okay, so I was wondering for your motivation using photo voice as your means of surveying the community rather than using like traditional surveys that people have used in the past.
Okay, luckily I have a slide prepared. So this kind of tells you about our larger research project. So there's kind of 3 data collection streams, and they all intersect, and we're trying to triangulate off of each other's findings. So intersectional vulnerability is my area. We have the political economy analysis set, and that is looking at document analysis, so local policies and regulations and things, but also they did a lot of in-depth interviews with people like regulators and local leaders and the staff of the CBS organizations and things. And then we also have a year-long high-frequency longitudinal phone survey where we asked people lots of questions, but the one that people are probably most interested in is every week we asked a set of questions about sanitation and what people used that week and how they found it. And yeah, so I guess the reason we chose photo voice was because we felt we were getting a good, like we were getting some quantitative data that gave us a pretty good idea over the year, but we weren't necessarily getting to the most vulnerable people in the households. Often, you know, it was the head of household who was using the phone. So we were purposively in this photo voice part of it, looking for people who we knew from the other two parts of the project and just spending time in communities were the most vulnerable, had the most impacts. Their vulnerabilities were impacting their sanitation experience. And we felt this was a really good way of getting their voices heard. Is that cool?
Great. I also actually had a question. I was wondering how you selected communities for this project.
Yep. So I'm not 100%. I mean, obviously there were communities that were using the three different CBS types. And I know that we went through a big process, but I've had 2 babies since then, and I cannot let me remember exactly how we decided which you can, yeah. Do you have a microphone for Alison? Maybe she remembers better than me.
Yeah,
there was a lot of thought went into it. I just can't remember it.
Yeah, so we were trying to select. We wanted cities where the CBS was provided in different ways. So in South Africa, it's provided by the municipality. Sanima is an NGO, and Sanergy is a social enterprise. So we had 3 different kind of governance types. And then once we selected the cities, we left the local universities and the CBS partners, implementing partners. We were like, well, this is where we've got a good concentration of CBS. So that one kind of was just logical. But yeah, there was some thought into picking those 3 cities, and no one had really. So when anyone who was at FSM5, we all went to a wonderful field trip and saw the CBS toilets, but no one had really like documented anything about them before.
In Cape Town.
Yeah, in Cape Town, yeah. So we've that was a really nice to be able to document what they're doing. They've got like 20,000 CBS units, which
it's actually like the largest CBS.
It's the largest, like Sanergy are like, that would be wonderful. And they're, what Sanergy's doing is really impressive, but they're not at 20,000.
Yeah.
Thank you so much. Thanks. Appreciate it. I think we have to move on to our next presenter for time, but thank you so much. All right, up next, we have a comparative review of wastewater-based methods for estimating the effective reproduction number, or RT, by Dustin Hill. Take it away.
Thank you for that introduction. So my name is Dustin Hill. I'm a wastewater-based epidemiologist from Syracuse University. I'll be talking to you about a project that we've been doing, which compares several different methods for estimating the reproduction number. So wastewater-based epidemiology actually starts where a lot of our projects do with people and, the waste that we shed from our bodies, whether it's feces, urine, or saliva. This approach is basically testing wastewater systems to identify community-level health indicators because when you use the bathroom, your body sheds a lot of things besides just waste. It sheds viral particles if you're infected with a virus. It sheds bacteria if you have that bacteria within you. It also sheds chemicals and drugs if you have ingested or intaken those things. And so basically from this, you can take a sample from a community and identify some sort of health impact, especially if you're looking at things like viruses like COVID-19. Basically, the process starts at the treatment plant. You take a sample and you send it to a lab. The lab will do an analysis, either PCR, using digital methods or real time, and then they'll send that to groups like me. So I don't work in the lab, I actually work on the data side, and I'm more of a data scientist. And what we want to do is take these lab samples that have been collected and evaluate them for the health indicators, and then link them up with clinical cases, where you can say how much SARS-CoV-2 is in wastewater, but unless you know how many cases are also in that community, it's hard to link those two methods or those two data sources together. Just another thing to note is that this has become very common in public health practice since COVID-19, but it's actually been around for decades. It's been widely used around the world for polio eradication. So it's not a new science, but it's much more prevalent in the public mindset these days. And so my focus today is looking at whether we can use wastewater surveillance to then predict epidemic trends. And COVID's the case study, but it has a lot of applications beyond COVID. So what is the reproduction number, the other part of this equation? There's two kinds. One is the basic reproduction number, which is the average number of secondary infections that a person will infect for a specific disease. So if the reproduction number is 2 and you're infected with the sickness, you will on average infect 2 other people. That's what the science tells us. And just for context, influenza's reproduction number is 1.28. So if you're infected with the flu, you'll infect on average 1 to 2 other people. The focus of today is looking at the effective reproduction number, or the RT, which is a value that changes over time. And this gives us epidemic curves that go up and then go down as infections spread. And this is the number of infections that one person is expected to spread, the number of daughter infections based on infections over the previous time period. There's an equation here. Is there a pointer? Yeah. That's from widely established. It was published in 2013 by Corey and colleagues. They also wrote an open source R package for it, and so it's widely used in the epidemic modeling community. So what did our team do with this project? We had 2 ideas. One was, as a team, we had a lot of ideas for applying wastewater to this calculation, because this is all based on counting infections, which is very different from wastewater surveillance, which is a quantitative sample of wastewater telling us about how much virus is there. It's not counting people. But so we wanted to see if we could take the wastewater surveillance data and apply it to get this number without having clinical data. And so as a team, we were like, well, we can come up with our own ways of doing this, or we can look at whether it's been done before or not. And we actually combined the 2 methods. We started with a literature search, and we found that there had been 20 articles published that were actually using wastewater epidemiology approaches to estimate the reproduction number. And across the studies, plus the ones that we came up with, we had 8 distinct methods. 4 of them were built around the equation that Corey and colleagues developed. 2 of them were actually quite straightforward. They used basic epidemiology measures of just lining up the linear change in quantification of the virus, and then looking at just the change over time in the rate of that value. And then there were 2 methods that were a little more innovative, using compartmental modeling and viral shedding approaches. And what we did was we took those 8 methods and we reproduced them for our data set, which was using New York State's wastewater surveillance program. New York State's been sampling wastewater for COVID and other things since 2020. And we have over 200 sampling sites across the state, covering the downstate region of New York City, which is highly populated, as well as upstate New York, which has some population centers, but it's quite rural in some areas. And so we wanted to see if that rural urban difference would provide some differences in the accuracy of these methods over time. Because the goal here is to say, we've got 8 different methods for calculating this number. Is any one of these better in certain situations, or how different are they from each other? And then we can recommend that for use in New York State's local health department, as well as other public health agencies. So our focus was model accuracy, but we needed a metric to compare the models to, because like I said, we were using wastewater data, not clinical case data. So we used the equation that I showed earlier and the infection counts for COVID as our reference method. And we wanted to see which method for wastewater was the closest in estimation to that case-based method. And accuracy was our goal. And by including all those sampling sites across the state, we could also say whether population coverage was a factor influencing accuracy. Is it better in these high population areas, or does it do equally well regardless of population coverage? We did all of our analysis in the program R, which is an open source statistical software. We chose it so that we could share all of our methods and packages. And we also selected it because 3 of the studies that we referenced built their entire program in R. And if you're interested in R and data science, we do have all of our methods online in an open repository. So this is what the reproduction number looks like when you map it out or plot it out. You'll see it's a change over time as the infection is growing or shrinking. The midpoint for the reproduction number is 1. When your reproduction number is 1, you have constant change. You're not growing or shrinking. There's one person infecting one person, and it's just not growing. But as soon as you get above 1, you know your epidemic is starting. You have infections growing. One person is infecting more than one other person. And that's where we don't want to be with any disease. And then as soon as you're below 1, you're at the peak of the curve. So right here, this is February 2023. That was right about when we peaked in New York and we started to decline last 2 winters. That was actually, yeah, last winter season, the end of that. The other thing that you'll see is that there's 8 lines here, and each line represents one of our methods that we compared. So there's kind of a spaghetti plot at times where they're very different, but there are, in general, times when they're all going up or all going down at the same time. So while they're not getting the exact same number, the values are sending these, or the wastewater values are suggesting the same direction and trend. And there's also times when they're really different from each other, where some are suggesting growth, some are suggesting shrinkage. So the models definitely varied in their performance. But looking at accuracy compared to population coverage, this was really interesting. Across the 8 methods, they all were correlated except for one of them very highly with population coverage, which makes sense. The more population coverage in a community that's on wastewater or on a sewer system, public sewer system where we could collect data for, the more likely that the wastewater data was going to reflect infections in that community. And then less population coverage we were less likely to capture those infection dynamics. But the fact that one of the methods was less influence is really interesting because it means it could work really well in rural settings in addition to more urban settings. So that was very cool. The plot I showed over time suggested, when you look at the averages, that the accuracy doesn't change very much. There were differences in the values, but definitely the trends were very similar across the methods. And so picking the best method based on which one was most accurate may not be the best way to select a method for a program that wants to use this method. So we also looked at how these methods differed in other ways. And so I mentioned wastewater data versus case data. 4 of the methods actually require the use of case data in the model calculation. And so they can't be calculated by wastewater data alone, which could be a significant limitation for adapting this to other diseases like RSV, which is not a reportable disease in most areas. In fact, in New York, it wasn't reportable until last year. So we want to use this method, but we actually don't have any case data prior to this season, which is an interesting conundrum. But 3, and actually 4 of the methods don't require case data in the calculation. You can actually just take a wastewater sample over time, as long as you have a time series of that data, and then you can use it to estimate the reproduction number for that pathogen. And so that's really promising for pathogens and programs who don't have good clinical data. The other potential decision-making factor for someone thinking about using this method for estimation is computation time and computational intensity. So 6 of the methods were very easy to use. They could be run on a basic computer in under 2 minutes, and most of them actually just a few seconds to calculate that number for a time series. But 2 of the methods, the more complicated ones, took several hours on a machine with a high amount of processing power, and we actually had to use high throughput computing to get estimates for the entire 200 sites across the state. And so that's a factor when you're thinking about using this operationally in real time as a public health agency who wants to track an epidemic. If you're going to pick one of those more complicated methods, you're going to have to either have the resources to compute that, or you're going to have to accept that you may not get an estimate in as timely a way or as timely as you might want. So just to wrap up some key findings, the RT methods that included the case data were a little bit more accurate. They're easier to use because you have case data to compare to. But we also found that the more complicated the model didn't necessarily mean it was the better model, especially with those ones that took a lot longer to calculate. They were getting very similar estimates to the simpler models. The other finding that was really interesting, I mentioned the 2 simpler epidemiology measures of linear fit and the change rate. They actually were simple to calculate and were doing equally well, at least in accuracy and in computation performance, to the other models. So if we just use more traditional metrics or simple metrics, we can get the same information. Limitations, our methods are highly dependent on the model developed by the researchers I mentioned earlier, their reproduction number equation. And some assumptions are hard to verify, like population coverage on sewer shed is all an estimate based on census data. So there's limitations there. And then using case data as a reference has its own issues because of different reporting standards. But just to conclude, we feel that wastewater can definitely be used to calculate this number and predict the epidemic spread. So it has a lot of utility there. And public agencies have a lot of choice when choosing a method for calculating this number. And it can be used for we think diseases beyond COVID like influenza and RSV. So thank you very much. And there's a lot of other folks behind this project.
Thank you so much. Are there any questions?
I don't need the microphone.
No, but we need it for the virtual audience.
Oh, okay. Yeah, thanks. Nice talk. So couple of points. Just how did you delineate fecal shedding of COVID in your model? So that's the first one.
So in the simpler models with the linear fit and the change rate, there's no inclusion of a fecal shedding rate. It's not necessary. But in the models that we referenced from the literature, fecal shedding was a key part of those. And so that those methods do require some knowledge about fecal shedding for that calculation. So for SARS-CoV-2, it wasn't too difficult because there had been literature on that. But for other diseases and pathogens, you might need to extract that information or figure out a way to calculate it. So it varied based on the method.
But the key benefit of wastewater data is that you don't need the case data to predict the epidemiological spread. So I just wondered how you delineate that in this model. You can't. Is that what you're saying? Or
you have to get that data, but I think the finding that if you could just use the percent change in wastewater, that correlates with the changes in case data means that you don't necessarily need the shedding rate to understand it, because your quantification of that over time is already capturing the change in infections and shedding.
Okay, thank you.
Yep.
Hi, thanks for the interesting talk. So COVID, later in the pandemic, I feel like people haven't actually been reporting their testing results, so clinical data might not be as accurate. So have you tried doing this process for the beginning of the pandemic, where we kind of have a better clinical data that would match the wastewater data a little more, and then applying those models then to calculate the later stages of the pandemic to compare the clinical RT with the wastewater RT that you get?
So yes, we did look at data prior to changes in at-home testing behavior and things like that with COVID, and the models did equally well. And I think it's more a product of how the reproduction number itself is calculated, where the period that would have an issue is when you have a significant change in testing behavior. But if you think your testing behavior is generally the same over time and you calculate it for that same time period, then the values should be accurate. That's kind of why we chose to exclude the earlier years of the pandemic. In addition to having continuous data, it's also the 2022 and 2020 through 2024 like testing patterns are much more similar than prior to when COVID first came around, when there was just mass testing. But yes, we did look at that, and there are differences in the when the testing behavior changes. But if you think your testing behavior is consistent, then this method, any of the methods work well.
We have time for about one more.
Oh, does anyone else want to go? Oh, okay. So, so the other aspect of disease spread is the difference between prevalence and incidence. Mm-hmm. So I just wondered if you had any thoughts on the use of this kind of model to better distinguish between those two aspects of outbreaks.
Yeah. So I don't know which works better, because we worked exclusively with incidence, but I think if you use prevalence, you're going to get different values. But I think like a different actual estimate for what the reproduction number is at that time. But I think it just means you should whatever data you choose to use, you just be consistent. Whether prevalence or incidence, though, is better for wastewater, that's a good question, because wastewater isn't just new infections, it is all the current infected individuals. But we used incidence, and it did seem to match up pretty well with our approach. That's why it's so interesting. Yeah. Exactly. Yeah. Well, thank you.
Thank you so much for that wonderful presentation. Our last presentation today is going to be from Innocent Tumwebaze, and he's going to be talking about the effectiveness of JENGU facilities to improve hand washing with soap in crisis-affected populations in Kenya.
Yeah, thank you very much. Good afternoon, and thank you for sticking with us. So we are diverting the discussion now, talk about crisis-affected populations, and I'll be talking about the JENGU hand washing facility. Just briefly about the JENGU hand washing facility. This is basically, just take it to be a normal hand washing facility that is mainly designed for promoting the washing of hands with soap. So it's basically a foot-operated hand washing facility developed by Arup, which is a designing and innovative kind of company in the UK. And it was basically developed together with different institutions, including British Red Cross and the London School of Hygiene and Tropical Medicine. So more features, it's a long-lasting, durable facility built basically with affordable and local available materials in the different contexts. So its components still robust with a mirror, provision for liquid or bar soap, plastic or stainless kind of basins. It has a disc fit for stability, a jerry can, a drain pipe attached to both the jerry can, but also to the hand washing basin, and it has a foot pump. And it also, the units are always attached together to deter any kind of theft issues based on the context which they're designed. Okay, so the study is based on a semi-arid area, which is Dadaab. Dadaab is basically located in the northeastern part of Kenya and bordering Somalia. So most of the refugees in this context are Somalis living in a camp with over 380 refugees. And the area is a semi-arid area, meaning that it has high temperatures ranging from 36 degrees to 56 in terms of humidity. And it's relatively flat with sandy loose soils. Yeah, in terms of the demographics, so the majority of the study respondents were largely female, and here we are looking at a sample of 300 respondents. I'll tell you more about that. And well, 59 were between 30 to 45 years, and most of them had never had formal kind of education. They largely depend on basically humanitarian kind of rations or services for their basic kind of well-being. Like I said, this is a Muslim-dominated kind of area, and they have access to water, borehole kind of water, piped water sources with pipe tap stands. And then the challenge is that, so they have access, but also they take more time to go to get water to their homes. Yeah, so this study was basically to understand the performance of this facility in crisis-affected populations. So it was the first kind of experiment in a refugee kind of setting, and we did conduct it in Uganda and Kenya, but here we shall focus on Kenya. And it involved different kinds of processes to get on board. The pre-intervention kind of activities that involve basic stakeholder engagements and getting to familiarize with the community. So doing like the field mapping, having interactive key informant kind of discussions with different groups of people, and also putting the different concepts together for the study. So after that, for the baselines, then we had to conduct a baseline, again, using different kind of methods, using surveys, household surveys, together with formative observations, and also still with the qualitative key informant interviews. So, and amidst all that kind of data, we also had to do hospital kind of data collection to look at basically the incidences or the prevalences of diarrhea diseases in the community as a whole. And then after the baseline, we did randomize the 300 households in which 150 group was getting the JENGU facility that was produced locally with soap. Soap was like a mediator in terms of the ethical considerations. If you're talking about hygiene, well, you can't talk about hygiene without some provision. So we had soap provided across the two groups. the intervention group that got the facility with soap, but also the control group that was also having soap, always provided at 2 months intervals in these areas. And after the first rollout of the intervention, we then had another evaluation to just see the initial kind of reactions in the communities in terms of behavior uptakes in improving their hand washing practices with soap. And then after 9 months, we did go back to do another evaluation. And also the other thing we did with the JENGU facilities, we also did a series of spot checks also after 2 months to basically see the conditions of the facility. Yeah, so the aim of the study, like we said, was to see if the provision or if access to a durable and stable stationed hand washing facility increases the hand washing with soap behaviors in these crisis affected populations. And that picture shows the facility being used in these communities. And so maybe talk about the results more. So during observations, we are observing all members of this homestead. So the survey, the household survey was with 1 person, but for the observations, we're observing all people that stay in that particular area. And what happened, so some have compound kind of houses, meaning that you have more than 1 family, so we're observing everyone. That means our enumerators were always moving in pairs as one was conducting the survey, the other one was also doing the observations, but it was structured in a way that we're interested in understanding the general livelihoods of people in that home so that we are not so much biasing also the data we're collecting. So what we show here are basically the hand washing moments by the different members of people. And maybe what I only project here is about the hand washing with soap. But in terms of the data we collected, so we have all the hand washing moments, all the times these individuals were supposed to wash their hands or not. So we also have the missed opportunities. So in terms of looking at that data, you would say, what do missed opportunities mean in terms of targeting, in terms of going forward? But here we also see that most of the people still wash their hands or they rinse their hands with water. So this is a small number that was only washing their hands with soap that we show here. And what these results tell us, for example, the first part. So this first part is only showing us the self-reported kind of hand washing with soap. And it gives us the baselines in terms of at the start of the study, at first month, and then the last period. And we see that there is relatively match the end results. So in terms of the self kind of, in terms of their genuineness, because they didn't know what was happening in the other groups, but you see, we don't see a lot of differences. And what they basically bring out is that overall we had a spillover, we had an increase in terms of the hand washing moments with soap compared to the initial baseline. But also what becomes interesting is that in the just 2 months after the rollout of the JENGU hand washing intervention, we see a lot of spike in terms of hand washing with soap practices. Of course, it's increasing in both groups, but the ones with the hand washing facility, JENGU, is higher compared to those that are using the different kind of mobile facilities. And what I should emphasize that largely, almost 100% of the communities in that area, they are using mobile facilities like a jug, or a bottle. That's what they're using for their hand washing practices. So when it gets to the end, we see a shift again in terms of hand washing with soap practices. So it comes out to say that those with the soap are they're actually washing their hands more compared to the ones that have both the interventions. And what that means in the long run, so becomes also a key factor respective of the facility, and it also depends on where a moment is being performed. So likewise, in terms of soap, we also try to see the soap availability. And here we see that looking at the this other bar, you see that again, overall, there's a shift in having soap closer to a hand washing facility, whether it was a mobile facility or it was a station facility, compared to before, where soap would be anywhere, not closer to the facility. And the same availability of soap. This is about soap. The initial was water, so overall they had access to water. So in terms of the performance of the behaviors, so largely we also saw some increase in terms of hand washing with soap for critical kind of behaviors. So which was also key in this study. But regarding the technology, as we summarized because of time, regarding the technology, we had different learnings. So while most of the technology itself is still, it's durable and everything. So when it came to the context and the nature of the basins for this community, for this settlement, there's actually super contrast because of the high temperatures. So the basins that were produced were not resilient to the weather condition. So it was a hard plastic basin that was more fragile to sunlight. So most of the basins then had to crack. So, and just this one tells us, so after 2 months, we had 27 of the basins that were affected, but in the long run, we had 51%. So what does that mean to us? Just coming to the summaries. So most of the basins were not suitable for that area. And it brings us the board to thinking about some of the design processes. Okay, in terms of, yeah, of course, this just brings about the current situation regarding the work in this area, COVID effect, security, the time, the language, and the weather events also affecting. And in terms of learnings, we say that basically soap is crucial and sufficient soap, because then it influences the practices and also prioritization if soap is limited. Then we talk about where hand washing moments can be performed in different areas. So meaning that a stationed hand washing facility that isn't flexible could have its limitations. And then one thing, the involvement of the stakeholders is important. Here we basically had to involve them from the start of the project throughout the whole process. Collaborations becomes key for all partners. And then in terms of the technology, like we talked about resilience, especially when it comes to basins. So we have a whole lot of probably also thinking about flexibility of the technology is also important. And we thank all our partners that really support this initiative. And lastly, thank you. Sorry for the rush.
So much. Are there any questions?
Thanks a lot for the presentation. I'm curious to understand better. You said the self-reported hand washing in the baseline and then again at the end line was basically the same, of about 50%, while in the end line, the observed hand washing incidence increased. Yes, exactly that slide. How do you explain that? Why do we have with the same self-reported hand washing more moments of washing hands? And maybe also a quick explanation again, how you actually observed the hand washing moments without impacting or influencing the behavior itself.
Yeah, thank you very much for those questions. So regarding observations of hand washing moments without influencing the behavior. So like we said, it was about the way we did sensitize the enumerators. And in this, like I said, we didn't go there to observe how they're washing their hands. We went there to see how on a daily way they live their life. You get it? So basically, understanding the livelihood, understanding the lived experiences of these communities. That's what we went there to do. And that minimizes the effect. And also, the more you engage with the communities then, because we use the numerators that were part of the society, part of the community. So people learn to live their own life. Otherwise, if it wasn't so, then you'd have a bias, you'd have super contrast between actually the self-reported and the observed kind of results. And in the long run, then they even get used to you. They live their life the way they live it. And this also explains probably the contrast between this, the post-intervention and the end, but also what also the results communicate is that in the long run, this is why I say SOAP becomes important, but also the technology had vulnerabilities of the basins. That means people also resorted to using back either their mobile facilities, or they went back to their normal kind of way of living using only water. Yeah, thank you for that.
I had a quick question just about your study population. I'm curious, given that this was a refugee population, how much people moved in and out of your cohort? Are these people who have been living here for a long time and lived here the whole 9 months, or was there significant movement in and out of the cohort during this period?
Yeah, thank you so much for that nice question too. Actually, these are people who had stayed in this place for long, but also during the study period, we actually were able to lose only 2 who were in the control group. But also what happened during some period, we had a period of floods. So where just some part of the sections had to be moved to a different area. But overall, it was a settled kind of population in the refugee setting, at least for the study period, that didn't move so much. Yeah, so we didn't have people moving out, actually. We didn't lose. Yeah. Thank you.
Thank you so much. I think that's time. One more round of applause. Thank you so much. All right, that wraps us up for today. I'm gonna ask people who gave a presentation, there's 10 more minutes if you want to hang around just to see if there's any questions. If you want to come up and speak to them, ask them a question, not in front of the whole room. If you guys are open to that, that would be great. I didn't ask them to do this beforehand, so this is a surprise. So if they run, you know why. But thank you all for being here, and thank you for listening.